giving me this honor of delivering the Dr. O.P. Gupta Oration. First of all, I would like to compliment Bansi for carrying out this meeting years on years with such a high academic content. And I think all of us feel a privilege to be over here in this meeting. I also feel very privileged and honored to give the Dr. O.P. Gupta Oration because we all know Dr. O.P. Gupta as such an astute clinician. He was the founder member of RSSDI, a very gentle and humble person. I think he's contributed to science in no uncertain terms. A lot of research that has been supported by him. Today, I'm going to talk about diabetes prevention because in the last about 3 years or so, we've had a lot of data that has come in, looking at some of the older studies as how they're faring in the long-term perspective. And if we just have to walk through that what is the magnitude of the problem that we see when we look at diabetes, I think we are all familiar that today we keep talking about diabetes prevention, but are we really succeeding in our endeavor to stem the tide of diabetes? And if we walk across the statistics, we find that we are still on a losing battle when it comes to the trends of diabetes occurrences. And when we look at the global data, we've got pre-diabetes in US about 96 million, in Latin America 9.8% of the population, in Brazil about 22% of the patients tend to have pre-diabetes. The reason why I talk about pre-diabetes because that's a huge volume of people who are just waiting to get converted to diabetes, and that's the pool of patients that we are not aggressively looking at. And perhaps our entire focus should be that rather than prevention of diabetes, how can you do prevention of pre-diabetes? Because if you do that, automatically the diabetes prevention is going to happen. And I think we tend to take it very easy when it comes to the term pre-diabetes. And that's when you talk about prevention of pre-diabetes, primordial prevention that we're really talking about. We've got this data from the ICMR in DIAB study, and it's not really different when it comes to our own Indian population when we see presence of diabetes in about 101 million population and pre-diabetes in about 136 million, making it together, these are the diagnosed population above the age of 18 years. We're seeing about almost 250 million people with either diabetes or pre-diabetes. But when we look at the criteria for diagnosis and the conversion for diabetes, and if you look at combinations of impaired fasting glucose, impaired glucose tolerance, if you have only impaired fasting glucose with the normal glucose tolerance, the incidence of conversion is about 33%, the odds ratio being 10. If you have patients with normal fasting glucose but impaired glucose tolerance, it's almost very similar. But when you have presence of both impaired fasting glucose and impaired glucose tolerance, the figure almost doubles to almost 64%. So obviously, it's just not good enough when we do a screening to look at fasting plasma glucose. You do have to look at also post-meal glucose values because the combination of both are really important when you look at interventions that is to be done at the level of pre-diabetes. So if you look at the ADA screening now, we talk about diabetes screening in adults with overweight or obesity, where BMI is classified as more than or equal to 25 and one or more risk factors. The screening should start at 18 years of age in all asymptomatic patients. And from, they have brought down the cutoff criteria from 45 years to 35 years because of the high incidence that we tend to see. Also, if you find that your initial screening is negative, then it should be repeated every 3 years or sooner if you find that there is a trend towards, the glucose tending to go up or there are multiple risk factors that are present in an individual. IDF went a step ahead and said that should we really be looking at 2 hours post-glucose values, or is 1 hour post-glucose value more representative of identifying a high-risk population? And they said that if you have a 1 hour post-glucose load of more than or equal to 155, in patients who have got a normal glucose tolerance during an OGTT, it is predictive of detecting progression to type 2 diabetes, micro and macrovascular complications, obstructive sleep apnea, and mast cell. And if you have a 1 hour post-glucose value of more than 209, then it's diagnostic of type 2 diabetes. From the RSSDI, we brought out an IDF position, endorsement of the IDF position statement, because this study was done by Dr. Mohan and his associates, and they published the paper, that if you look at 1 hour post-glucose load in the Indian population, then it defines a high-risk patients of type 2 diabetes in adults, children, and youth. It is associated with worsened metabolic and atherogenic profiles. It identifies micro and macrovascular complications and morbidity and mortality. It occurs before the onset of impaired glucose tolerance. And more important, they may benefit from lifestyle and pharmacological interventions to reduce the progression to type 2 diabetes. So I think it's important, whether you look at 1 hour or 2 hour post-glucose values, 1 hour being a little more easy to do because patients, when they come to you, waiting for 2 hours become more difficult. But 1 hour is equally good or perhaps better when it comes to identifying a high-risk population. As I said earlier, that pre-diabetes is extremely important because that's a population of people that is waiting to get converted, and it's a population where we often overlook because of mild elevations of the blood glucose values. So we dismiss it as inconsequential, and we then think that we don't even follow them up. But important is that we need to look at the trends of glucose and A1Cs in this population to see who are the people who are converting to glucose over diabetes. And I'm going to come some thoughts about this, which was published in Diabetology in 23. So if you look back in the Whitehall study and you look at patients who were diagnosed diabetes and trace the history backwards, the Whitehall study looked at almost 14 years backwards. Now, people who were destined to develop diabetes showed reduction in the insulin sensitivity even 14 years backwards, and an acute loss of insulin sensitivity almost 5 years before the diagnosis of diabetes. The body tends to compensate adequately well, and that's the reason why they don't tend to develop a glucose intolerance. But as they near the, or the period when they tend to develop over diabetes, the insulin sensitivity sharply declines, and you find that the postprandial glucose tends to go up. And you need to be mindful of the fact that these are the patients who need to be looked backwards. And that's why when you look at some of the studies which are looking at in utero studies, which I'm going to allude to now, we have to start identifying patients who are destined to develop diabetes with various sort of biomarkers or clinical profiles or maternal in utero environment, which are going to predict long-term occurrences of diabetes. Now, this was the paper in Diabetology, and they said that we need to really strike a balance between risk and resources. So who are the population of people that we should be really screening very aggressively, and are our cutoff points very liberal or very stringent? They said, should we start using the term pre-diabetes at all? Because only 25% of the patients who develop pre-diabetes convert to diabetes. So are we really wasting our time and resources to prevent an unlikely disease which may happen in the larger population of the people? Scenario 2 would be that if you have a diagnosis of pre-diabetes, then it sends a signal of urgency that you need to do more for these patients to prevent the conversion. So you tend to do a lot of highly intensive, demanding lifestyle-based interventions and offer it to people so that you can reduce the diabetes incidence by about 50%. And 40% of the adults which are designated as pre-diabetes. The scenario 3 is stop using the term pre-diabetes, and everybody is termed as diabetes because your intent is not glucose control, but the intent is to reduce the burden of diabetic complication which is going to come from the occurrences of diabetes. So they said that just lower the thresholds of diagnosis and don't use the term pre-diabetes, and everybody becomes a diabetes, because the ultimate aim is to see that patients don't end up with diabetic complications. And the last is, of course, you risk stratify an individual. And based on risk stratification, you decide who are the people who are going to be at a high risk for future diabetes and start doing highly intensive interventions so that you can reduce the incidence of diabetes by 50%. Now, risk stratification is something which is very individual, and we don't have very robust sort of risk stratification criteria to decide that what are the long-term profiles of these patients who will tend to convert. So some of the markers that have been listed for primordial prevention or prevention of prediabetes when you look backwards is, if you have, these predictors of transition from normal glucose regulation to pre-diabetes, where you look at demographic and adiposity measures, which is age, sex, high BMIs, high waist circumference, and adiposity, more important, because it's a area which now is gaining a lot of attention when we talk about adiposity. And then, of course, you look at their lower insulin sensitivity. You can do the HOMA-IR in high-risk populations, calculated HOMA-IR for that matter. Look at the disposition index. High triglycerides has become a very important entity because we don't really look at triglycerides in a very serious sense, but today we do recognize that high triglycerides are responsible for insulin resistance. They're responsible for mast cell occurrences and so many other, ectopic fat deposition that stems from high triglycerides that come in. So GDM is perhaps one of the most important opportunities that you should look at for a non-communicable disease prevention. And that's where the story actually starts. And a lot of studies that have been done by Dr. Yagnik in a very path-breaking way stems from the studies that have shown long-term occurrences of non-communicable diseases in high-risk mothers who tend to have offsprings who are undernourished. Now, when you have GDM, it affects two lives, of course, as we know that. The diagnosis of GDM identifies women at a high risk for future diabetes and associated metabolic problems. And maternal hypoglycemia is associated with development of metabolic problems in the offspring. If you look at the statistics and prevalence data, what is the short-term impact of GDM? So the maternal morbidity and mortality due to complications as excessive birth, hemorrhage, hypertensive disorders, obstructive labors, all these are sort of immediate complication of GDM that they tend to have, and very high likelihood of preterm births, so leading cause of death in children under 5. But we are more concerned about what is the long-term impact they tend to have. So they have a highly increased risk for developing non-communicable diseases such as diabetes, obesity, and hypertension. About 50% of the mothers with GDM develop type 2 diabetes within 5 years. And a child is up to 8 times more likely to develop type 2 diabetes if the mother had untreated gestational diabetes. We are familiar with this complex graph, but we are a paradox, as Dr. Yagnik always says, between undernutrition and overnutrition. And I think that's where stems the lies that we tend to have a higher amount of adiposity. A childhood obesity becomes so born thin becomes suddenly big, and they tend to develop a high amount of adiposity and insulin resistance. And that's where the whole story starts of developing insulin resistance and future diabetes. But his landmark paper of early life origins of epidemic of the double burden of malnutrition and life can only be understood backwards. This is a paper that I urge all of you to read. And what he really spoke about was that fetal under and over nutrition may program the risk for future diabetes and obesity. There is a multi-generational undernutrition which increases the susceptibility to obesity even at normal nutrition levels. And BMI can thus be interpreted as a composite index of undernutrition and overnutrition. So what he really says is, by the time you're actually looking at the diagnosis of prediabetes and diabetes, you've already missed the bus. So the hope of shooing away diabetes pandemic by controlling lifestyle of adults and using biologics is tantamount to closing the door after the horse has bolted. Only promoting adolescent and female health in the reproductive years will help primordial and primary prevention in future generations. So when we talk about diabetes prevention, what should be a call for action that we really need to look at? And this is a paper which is very important to look at, which is and Dr. Mohan and his associates were also part of this paper. We need to have identification of which is the target population that we are really looking at. So who's at risk? Is there accessible to treatments? Is there acceptability? What should be the population target that we should be looking at? Is there a social needs support? Is there a group alignment? When should we be doing the intervention, counseling, nutrition, the lifestyle programs, medication? So when should these be initiated and where should they be done? In person, online, distance-based, community-based, any of these. So in my perception, I feel all these are important. wherever you have an opportunity to intervene, you should just do that, because it's going to help the patient one way or the other. This is the Chinese model, and this has been a very successful model which was published in Lancet last year, where they looked at primordial prevention, where they said, let the whole population be screened for non-communicable disease and encourage healthy lifestyles. So you promote physical activity, control cigarette smoking, moderate alcohol consumption, improve mental health, all these sort of things should be done in every person in the general population. When it comes to primary prevention, you look at high-risk population. So you do a very targeted screening and do lifestyle interventions and drug interventions in the targeted population. And when we talk about secondary prevention, you identify the diabetes population and you sort of address the risk factors that we've got and look at the blood pressures, look at the lipids, look at the blood pressures, and so many other risk interventions that you do. And you need to do a multiple risk interventions if you want to reduce the outcomes of diabetes when it happens over the long duration of time. But this is a paper by Dr. Ramchandran, which is more relevant for the Indian population and talks about feasibility of prevention of type 2 diabetes in the low and middle income countries. And what he says is, awareness creation is important, so do community outreach programs, involvement of the government and non-governmental organizations. And this can be done through public campaigns, electronic media. Do a risk stratification of individuals, which is simple, acceptable to the public, economical, and implementation at a large scale. So you do opportunistic screening, do a risk score, and do blood tests. Then you plan the program by choosing target populations. Design and execution should be done meticulously, and intervention and modes of delivery should be identified, and use your resources very properly. And then, of course, you do an outcome evaluation by monitoring cost analysis and long-term sustainability. But he's also put in a word of caution that there are many barriers and challenges to implementing lifestyle intervention programs. And this is very relevant to our population, where we find that we talk about lifestyle intervention, but what is the success rate when you look at long-term implementation of lifestyle program? It's dismally low. And that's perhaps because of individual barriers, societal barriers, and it could be healthcare support systems that we tend to have. So all these are very important to do. And this is again from the diabetes prevention study, where they looked at the problem. So when you have a high pre-diabetes burden, they've looked at over the years, all the way up to 2020, the prevalence of diabetes has just been increasing. We have not really changed it very much. But when you look at the stagnancy of the lifestyle changes that has happened, and it hasn't changed the outcome in terms of diabetes progression, it's been very, very bad. And there are many barriers as they identify even in the US, which is as relevant as much as it is to our population of people. So this was a paper that we all brought out from India, and many of you are present over here in the audience. We said that this may be a risk stratification score that may be relevant for us, and these are non-invasive risk scores for Asian Indians, where we look at age, family history, body mass index, waist circumference, sedentary activity, and you score them and look at what is the maximum score. So what we recommended from this paper was, step one should be screening to identify high-risk individuals using a non-invasive risk score, as I've just said, and you look at the cutoff value and identify the population of people who should be really screened and make optimized resources of what is available. Step two should be diagnosis of prediabetes or intermediate hyperglycemia. So you look at the fasting plasma glucose, look at the 1-hour glucose value, 2-hour glucose value, and the A1C. And step three is, of course, put them on appropriate diet, physical activity, and medications, as you know, we'll talk about it in the coming slides. This was, I think, one of the largest funded study by RSSDI, conducted by Dr. Madhu and many of the associates that are present again over here, where they looked at the role of yoga, and they found that there were about 900 odd patients that were randomized. 488 had yoga plus lifestyle, and 486 were lifestyle alone. And when they looked at 3 years follow-up, there was 39% reduction of relative risk of diabetes with yoga as compared to lifestyle alone that we were looking at. So it's not just dietary control, that's important, but a physical intervention is equally important. And you find clearly that yoga is something that we all promote in our country. Our Prime Minister promotes yoga, and it is something that is inherent to our country, our culture. And just promoting yoga itself along with lifestyle intervention has been beneficial in the largest sense to bring down the incidence of diabetes. We've had landmark diabetes prevention trials, and one of the notable one is the Indian Diabetes Prevention Study, which was conducted by Dr. Ramchandran. They looked at impaired glucose tolerance, age group was between 33 to 55. They looked at diet, exercise, metformin, and there were three, and now of course it's come out with the long-term follow-up also. But at the end of 3 years, 28% had improvement or sort of prevented diabetes by diet and exercise, use of metformin about 26, and all three put together about 28% of the people had reduction in the progression to type 2 diabetes. We've had a number of pharmacological interventions that you can see over here, which we have seen over a period of time, which has shown clear benefit, and most of these trials were with acarbose, metformin, ramipril, nataglenide, pioglitazone. So they're all the different pharmacological agents that have helped to understand this. I'm just going to go a little faster in interest of time, but this was a study that was published in this year in July, where they looked at the DPP and DPP outcome study. What were the outcomes that were looked at? At the end of 2.8 years, the lifestyle intervention reduced diabetes risk by 58%, and metformin reduced diabetes risk by 31%. At 15 years, the lifestyle intervention reduced diabetes risk by 27%, and metformin reduced diabetes risk by 18%. And at the end of 21 years, which is the latest one that has really come forth, the lifestyle intervention reduced diabetes risk by 24%, and metformin reduced diabetes risk by 17%. These were all the follow-up of the original cohort that was studied. So what you can look at is at the end of 21 years, they're still seeing the benefit of the initial population that was done for screening for the DPP study which was initiated. So there is a long-term benefit that we look at. I'm sorry for skipping some of the slides because of time, but I'm going to come now to the last section of my talk, that we talk about weight reduction, and we talk about weight as an important criteria for insulin resistance, occurrences of diabetes, and we find that as weight goes up, the incidence of diabetes also tends to go up. And we talk about important is diet, exercise, and we have got, of course, the direct trial which has looked at very low calorie diets, and they've looked at what is the percentage of people that tend to benefit by achieving a remission. And you have, of course, that in the control and intervention group, the percentage of people who had more than 15 kilograms of weight loss at 12 months in the intervention was 24%, and they had almost 46% of chances of getting diabetes remission. But at every 5%, 10%, 15% of weight loss, you had an escalating remission of diabetes that tended to occur. Today we've got a host of medicines, and we talk about can we use GLP-1 analogs earlier as a first line treatment. And you've got great data that has come in, and this paper was published by Osama Hamdi in 23, which looked at all the different GLP-1 analogs in the early population, whether they are impaired glucose tolerance or impaired fasting glucose. And these are sort of short trials that are there of less than 1 year, and they've shown a great reduction in conversion to diabetes. This is with liraglutide, with exenatide, semaglutide, and now with, of course, with the SURMOUNT-1, you've got with tirzepatide data, where almost 95.3% of participants with prediabetes at baseline in the treatment group that reverted to normoglycemia, as compared to 61.9% in the placebo group. So I'll just end up my talk by saying that lifestyle interventions are effective and appropriate. We need to encourage it more. It's difficult to follow, there are high failure rates, and there is poor weight reduction that tends to happen. The pharmacological interventions in conjunction with lifestyle are much more effective in high-risk individuals. Weight loss through intensive lifestyle modification and medications have shown significant benefit in reversal of prediabetes and diabetes, but sustenance of weight loss remains a key issue. And lastly, to bring down the burden of diabetes, we need to do mass screenings and increase awareness of diabetes in communities. This is a communication by the WHO where they've talked about this paper of reducing the burden of non-communicable diseases through strengthening the prevention and control of diabetes. And what they really talk about, 5 voluntary global diabetes related targets for 2025. They should be aiming to a 25% relative reduction in overall mortality. We need to halt the rise in diabetes and obesity. At least 50% of the eligible people should receive medicinal treatment, including glycemic control and counseling to prevent heart attacks and strokes. In 80% availability of affordable basic technologies and essential medicines, and we need to push our governments to do more, and a 30% relative reduction in prevalence of current tobacco use in persons of age of 15 years and more. I'd like to thank you for your patient listening, and I'm sure that between lifestyle interventions and pharmacologic treatment, we oscillate, but what matters is what are we achieving at the end of the day. We need to do aggressively more. Thank you once again.